Our final presenter today is Dr. Aaron Friedman. Come on up.
Thank you so much. Thank you for the opportunity to present. My name is Dr. Aaron Friedman. I'm an associate professor of otolaryngology, or ear, nose, and throat surgery here at the University of Cincinnati. I'm also a laryngologist, which is to say that I have subspecialty expertise in voice and airway surgery. I've been in clinical practice for 14 years and performed over 2,000 surgeries on the vocal cords and airways. And my goal here is to present a simple device to improve surgical efficiency in the operating room. This seems to be on auto-populate here, so I apologize for that. This is how we do surgery on vocal cords. You can see that there are small little lumps sometimes on the vocal folds, and what that does is they can impact the quality of the voice. Much like a pebble in your shoe, small lesions can create big problems. We have to operate at high magnification in order to be precise, and our instrumentation also has to be precise as well, too. Here you can see that some of our instruments and the lesions we operate on are fractions the size of a penny. We really need precision, both in terms of the surgical instrumentation and the ability for us to use that instrumentation. On the other hand, airway surgery is performed under general anesthesia to enlarge a narrow airway. Here you can see a breathing tube that's been put in to allow the patient to breathe, but we have to take that breathing tube out in order to be able to operate. And we really need sort of, we often can have as little as 30 to 60 seconds within which to treat an interval before we have to put that breathing tube back in. And so what we really need is that the instruments pass to us with speed. It is the job of a surgical technician to pass instruments back and forth to the surgeon. And this can happen anywhere from 50 to 100 times during the course of an average surgery that I do. These are a sample of the bewildering array of instruments that we have that are very different, but subtly different. And so a surgical technician that is familiar with those instruments and is familiar with the types of operations we do can often pass them very efficiently. But I just heard this quote 2 days ago when I was operating, and I've heard it many times before. The scrub tech will sometimes come in and say, "I've never scrubbed this kind of case before." And the setup will look something like this. So as Forrest Gump says, you never know what you're going to get. But the statistics actually tell you otherwise, because hospitals on average have 100% staff turnover every 5 years. And from the perspective of a scrub technician, more than 50% of them are gone within 2 years, and by 4 years, more than 2/3 of them are gone. So the likelihood that you as a surgeon will operate with a scrub technician that both knows your equipment and the case you're doing is diminishingly small. And this problem is only worsened with the pandemic and healthcare turnover. So the current solutions that exist for this really involve self-serving instruments. So the suction is one of the instruments we put back and forth into the airway, and some surgeons will just tuck this under the patient's shoulder. Other surgeons have come up with sort of home-brewed solutions. This is a large metal pipe that basically is there to sort of serve as a holster, and instruments can be put in and out of it as needed. But it doesn't really solve the problem of being able to put multiple instruments there. But probably the most common solution is just for the surgeon for him or herself to go self-serve the instruments that they need if the scrub technician is having trouble finding it. And here you can see our scrub technician is in the middle, and the surgeon has gotten up from her operating room chair to go find the instrument she needs, and then goes and sits back down. So what we propose is a bed-mounted instrument tray, and this is a prototype device that we've used and tested. It's ergonomic. It has, in this iteration, 3 holders for instruments, and there's 1 on each side. It avoids wrong instrument passing because once that tray is loaded with the proper instruments, the surgeon can self-serve instruments back and forth to himself. We really view it as a scrub tech equalizer, meaning that you can take a novice scrub technician who hasn't performed the kinds of cases and worked with that surgeon and elevate them to the efficiency of somebody who has. In our preliminary testing in a randomized controlled fashion using this versus conventional scrub technicians, we found that it increased operative efficiency in terms of instrument passing by 3-fold. And really what this allows the surgeon to do is focus on the operation and not be distracted by the instruments. So what is the market for something like this? Well, I've already shown you what's called direct laryngoscopy, and there's about 14,000 of those done per year in the United States. But it turns out that there's an additional market that's probably an order of magnitude bigger for certain types of surgeries. And in particular, endoscopic sinus surgery and neurosurgery are the two surgical types that I've talked to that feel that there's a need for something like this. We envision a device that itself has a reusable component that attaches to the bed, but has a disposable component that is specific to the type of instrument that's used. So on a per case basis, we think that if even 50% of these cases use the device like this, the revenue approaches somewhere north of $9 million. So what is the pathway forward for our product? Well, we've already designed and tested a prototype, and we've applied for a full patent. What we need help with is developing and testing a next generation prototype, testing this outside of the University of Cincinnati, developing a business model, getting FDA approval before we can take something like this to market. Our team consists of myself as well as a biomedical engineer who has a master's in that and a medical student here. And I've already talked to a number of colleagues who are willing to serve as consultants, but we do need an EIR to take this to the next level. The bed-mounted instrument tray. Help us make lives a bit easier for surgeons by providing the right instrument at the right time in the right place. Thank you.
Thank you very much,
questions?
Aaron.
Doc, when you got 60 seconds, how do you feel when the instrument doesn't come to you?
I'm sorry, can you repeat that? Sorry.
When you got 60 seconds to do something,
Yeah.
and the instrument doesn't come to you, how do you feel?
Right. I mean, it ends up being stressful, right? And this is a stress-reducing component for surgery with those time-critical surgical steps. So yeah, good question. I think we're done.
Our neighbors
Yeah,
are
go
upset.
You guys talked about the ability to actually patent this, like given it seems like it'd be possible to come up with a lot of alternative designs that would accomplish the same end goal.
Have we?
So I'm just curious if you've looked into like the patentability of it, or if you think that would actually provide a mode or not.
Yeah, we did apply for a full patent, and so part of that was the preliminary patent search to do that. And surprisingly, there's not a lot out there that's done for this. And you know, we specifically looked at patenting this for what we call endoscopic surgery, and certainly nothing has been done in that space. But our patent is fairly broad in terms of the application, and there's nothing on the market that really sort of approaches. There really is no market device that approaches this. So yeah.
Thanks.
Sure. Thank you.
Thank you. Okay. Thank you, Aaron. Okay, I think the construction upstairs is just about our cue to get out of here. There are just 4 things I needed to remember. Okay, so first of all, I want to say thank you very much to everyone who has helped support